Hello everyone, I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. In this session, I'll be doing a quick recap on this topic of the hyperthyroidism, which is nothing but your thyrotoxicosis. So, first of all, you should know what is the most common cause of the hyperthyroidism. The most common cause of hyperthyroidism, it is the Graves' disease. And what is this Graves' disease? Let me tell you, it is an autoimmune disease. Right, Graves' disease, it is an autoimmune disease where the antibodies are being formed against the thyroid follicular cells. And next, what is the pathogenesis in the Graves' disease? So just now, as I was discussing with you, that it is an autoimmune disease, the antibodies are being formed. So the question that they will be asking you is, what is the name of those antibodies? So remember, the name of those antibodies are thyroid stimulating immunoglobulins. This thyroid stimulating immunoglobulins will stimulate the follicular cells to secrete T3 and as well as T4. That is a pathogenesis in Graves' disease. Next. How is the thyroid gland in the Graves' disease? So definitely there will be a goiter, but you have to remember that it is a painless goiter, right? It is diffuse painless enlargement of the thyroid gland. That is what you will see in the patients with the Graves' disease. Then, yes, what are the causes of intrinsic thyroid autonomy? So whatever we have discussed was the Graves, which was the most common cause of thyrotoxicosis. Now the question is, what are the other causes of the hyperthyroidism? So intrinsic thyroid autonomy. What do you understand by this? That means without the help of TSH, the thyroid gland itself will be producing excess amount of the thyroid hormone. And those conditions include toxic adenoma and as well as the toxic multinodular goiter. And this toxic multinodular goiter, it is called as the Plummer's disease, right? This is a very important area where the questions can be asked. So now, what is the Plummer's disease? Right? So let me explain you that the Plummer's disease is the one which is seen in elderly individuals, right? And it is a non-autoimmune condition. Graves was an autoimmune condition, but this is a non-autoimmune condition. And these patients with the Plummers, they are commonly associated with the development of the arrhythmia and as well as the congestive heart failure, right? That's a very, very important point related to your Plummers. Next. Yes, what are the causes of the transient hyperthyroidism? That means the hyperthyroidism will be there only for a short period of time, and that includes subacute thyroiditis. And please remember, Graves was a painless diffuse enlargement of the gland, but whereas your subacute thyroiditis, it is the painful enlargement of the gland. And one more condition we have causing transient hyperthyroidism, that includes the lymphocytic thyroiditis. So lymphocytic thyroiditis, it is a painless postpartum condition, right? Lymphocytic thyroiditis, it's a painless postpartum condition. Okay, so these are the causes of transient hyperthyroidism, where the hyperthyroidism will be there only for a short period of time. Then followed by that, very, very important question, what are the drugs that will cause the hyperthyroidism? See, the drugs that will cause hyperthyroidism is the amiodarone. See, amiodarone is associated with amiodarone-induced thyrotoxicosis and as well as the amiodarone-induced hypothyroidism. So the mechanisms I have explained in my quick recap on the hypothyroidism. So you can just refer that particular session of the hypothyroidism for the mechanisms how amiodarone will cause hyperthyroidism or the hypothyroidism. Next. Now, what are the agents with excess iodine causing hyperthyroidism? See, we have iodinated contrast agents, and these iodinated contrast agents, they are mainly useful for the imaging studies. So these iodinated contrast agents are the one which contains the excess iodine, which may make the individual to develop the hyperthyroidism, right? Next. Yes, what are the extrathyroid source of the hormones? Extrathyroid sources of the hormones, it includes number one, the thyrotoxicosis factitia, right, where the individual will be taking exogenous thyroid supplementation, and the other one is the ectopic thyroid tissue. Now, what are the tissues outside the thyroid which will be producing the thyroid hormone? Is one abnormality, that is stroma ovary, and then functional follicular carcinoma. So these are the extrathyroid sources of the hormones. So regarding thyrotoxicosis factitia, remember, it's a false hyperthyroidism. The individual will be pretending that the individual is having hyperthyroidism by exogenous supplementation of the thyroid. So these are the extrathyroid sources of the hormones. Next. Yes, what do you understand by this word? Secondary hyperthyroidism. See, secondary hyperthyroidism means the pathology is in the pituitary gland. The pituitary gland will be producing excess amount of the TSH, right? And this TSH will be acting on the follicular cells of the thyroid gland that will produce T3 and as well as T4. That is called as the secondary hyperthyroidism. Then followed by that, yes, what are the features of the Graves' disease? So Graves' disease, as I have said you, right, it's an autoimmune disease and it is diffuse painless enlargement of the gland. So in these individuals, there will be a toxic diffuse goiter, right? It will be a toxic diffuse goiter. In the sense, there will be enlargement of the gland and the individual will be having the protrusion of the eyeballs, right, which is nothing but your exophthalmos, and then dermopathy. So these are the important manifestations in patients with the Graves. And regarding dermopathy, let me explain you. Yes, so this is what is nothing but your pretibial myxedema, right, which is nothing but the thyroid dermopathy, which is seen as a manifestation in patients with the Graves' disease. Then, yes, what is the age group commonly seen with Graves? The age group commonly is around the age group of the 50 years. And you should know, Graves, is it more common in females or males? Graves, it is more common in females rather than males, right? Because it's an autoimmune disease. Autoimmune diseases are more common in females rather than males. So please remember, the Graves is more common in females. Next, what about the genetic component in the Graves' disease? So let me tell you that the genetic inheritance, it is very much significant. That is, a person is more likely to be affected if they have the family member with the same disease of the Graves' disease. So they have a very significant genetic component regarding this Graves. Then, yes, what are the triggering factors for the Graves' disease? So let me tell you, the triggering factors for the development of the Graves' disease include the following. Number 1, stress. Number 2, infection. And number 3, pregnancy. So these are the triggering factors for the development of the Graves. And what are the other associated autoimmune disorders in the Graves? See, most of the times autoimmune disorders, they remain associated with one another. Like with Graves, the autoimmune disorders which is associated is type 1 diabetes mellitus, where the antibodies are formed against the islet cells, and the pernicious anemia, right, where the antibodies are being formed against the parietal cells of the stomach, where the individual will have the vitamin B12 deficiency. So these are the autoimmune disorders which are associated with the Graves. Then, what is the risk factor that worsens the exophthalmos? This is a very, very important multiple choice question. So it is your smoking, right? Smoking causes increased risk of the disease and may make the exophthalmos worse. That is what is your the risk factor that will worsen the exophthalmos. Then, yes, what are the neurological manifestations in Graves? The neurological manifestations in Graves will be anxiety, tremors, psychosis, because the thyroid hormone will be firing the cerebral neurons, and that is the reason why the individual will develop the emotional lability, inability to sleep, and as well as the tremors. So these are the CNS manifestations in Graves. And if you take the cardiovascular manifestations in Graves, that includes, so the thyroid hormone, let me tell you, it has the sympathetic activity on the heart. In the sense, it will excite or it will increase everything. So there will be arrhythmias, most commonly atrial fibrillation, right? And there can be dyspnea, palpitations, angina, and possible cardiac failure. So why is that angina? Is because these thyroid hormone, whenever it is increased in quantity, the myocardial activity is increased. So activity will be more, right? Demand is more, supply will be less, and that makes the individual to land up in angina. And what type of heart failure you can have with in case of Graves? It is hyperdynamic heart failure, which is nothing but high output heart failure. And what are the GIT manifestations in Graves? So GIT manifestations in Graves, if you observe, the thyroid hormone will increase the gastrointestinal motility. So that is the reason why the GI manifestations will be in the form of diarrhea. Next, how is the metabolism in Graves? Remember, Graves, it is a hypermetabolic state. So that is the reason why these patients, they have excessive sweating, they have heat intolerance, they have weight loss, and they also have increased appetite. So that is how the metabolism will be there in patients with the Graves. So there will be weight loss despite increased appetite. Okay, next. Now, what are the musculoskeletal manifestations in Graves? Let me tell you that these individuals will have osteoporosis. Why? Because the thyroid hormone will stimulate the osteoclastic activity. Okay, so even if you take the muscle, there will be proximal muscle weakness. So why is that they'll have proximal muscle weaknesses? Because thyroid hormone will cause the proteolysis, right? And the skeletal muscles are made up of the proteins. So that is the reason why there will be excessive proteolysis in Graves, resulting in the proximal muscle weakness. So that is about the musculoskeletal manifestation in Graves. Then now, what are the ocular signs in Graves? Just now we have discussed the ocular signs in Graves will be exophthalmos, and due to which the individual will have a staring, infrequent blinking, and as well as the lid lag. So these are the ocular signs that you will have in patients with the Graves. Next, what will be the menstrual irregularity in patients with the Graves disease? Menstrual irregularity will be in the form of the oligomenorrhea. Right, it will be in the form of oligomenorrhea, where the individual will have decreased menstruation. The menstrual cycle will be with every more than 35 days. Normal menstrual cycle, it repeats every 28 days, but here in oligomenorrhea, it repeats for more than 35 days. Right, after 35 days, then there will be a next cycle. That will be your oligomenorrhea. And what are the skeletal manifestations in the Graves disease? So this is what I was about to tell you. In hyperthyroidism, there will be increase in the osteoclastic activity, and thereby there will be increased bone resorption, resulting in osteoporosis, and at the same time there will be hypercalcemia. And at the same time there will be hypercalcemia, because the osteoclastic activity, what they will do, they will cause bone resorption and they will increase the serum calcium levels, and that will result in what is called the hypercalcemia, right? Next, what will be the skin manifestation in Graves? Let me tell you, these individuals, they'll have profuse sweating. Why is that? That is because of increase in the basal metabolic rate. So they have warm and moist skin. So the body temperature is elevated because of excess basal metabolic rate. And they will have palmar erythema along with fine and silky hair in patients with the hyperthyroidism. So these are the skin manifestations that you will come across in patients with the Graves. Now, what are the laboratory studies in Graves? Laboratory studies in Graves tells you that there is increase in T3 and as well as T4, but what will happen to your TSH? The TSH will be reduced. So that will be the laboratory results in the Graves. So decrease in TSH, and there will be high serum free T3 and as well as T4. These are the laboratory studies. Now, what will happen to your radioactive iodine uptake studies in Graves? This is a very important question. So there is increased radioactive iodine uptake in Graves. Now, at the same time, you should know what will happen to radioactive iodine uptake in case of thyroiditis. So there is decreased radioactive iodine uptake in patients with subacute thyroiditis and as well as the factitious hyperthyroidism. Factitious hyperthyroidism, I have taught you, it is exogenous thyroid hormone supplementation. And yes, what are the other investigations in Graves? That includes there will be elevated thyroid stimulating immunoglobulin, which is nothing but the antibody, and then antithyroglobulin and antimicrosomal antibodies. So these will be the other investigations in Graves. Next question is, in the coming to the treatment of your Graves. See, as a part of the treatment of Graves, you will be adding the beta blocker, that is propranolol. Now, what is the rationale of adding propranolol? Let me tell you that in patients with hyperthyroidism, there is excessive sympathetic activity. Right, there is excessive adrenal hyperfunction. So mainly to treat that adrenal hyperfunction, we add this propranolol. So propranolol, it blocks the beta receptors and thereby it will reduce the heart rate in patients with hyperthyroidism. And not only that, it will also reduce the tremors in patients with hyperthyroidism. And not only that, propranolol, it will also inhibit the peripheral conversion of the thyroid hormone. It will inhibit the peripheral conversion from T4 to T3. So that is about an important point related to your propranolol. Now, you need to know what are the antithyroid drugs that you need to give for the hyperthyroidism. So in hyperthyroidism, the drug of choice will be the thyroid peroxidase inhibitors. And among that, the important thyroid peroxidase inhibitor is the methimazole that we need to give. And we have another important thyroid peroxidase inhibitor, that is propylthiouracil. So what these drugs will do, they block the synthesis of the thyroid hormone. Okay, next. Now, what is the advantage of methimazole over the propylthiouracil? Why are you considering this methimazole as the drug of choice? Because methimazole, it has the few side effects compared to that of your propylthiouracil, and not only that, it has longer half-life compared to that of your propylthiouracil. That is one advantage, and the other one is the few side effects then compared to that of your propylthiouracil. Then now, when is this propylthiouracil added then, right? When do we use this propylthiouracil? Let me tell you, this propylthiouracil is mainly used in first trimester of pregnancy, right? It is mainly used in the first trimester of pregnancy only. Now, why is that? Because methimazole is teratogenic. That is the reason why we don't use methimazole in the first trimester of pregnancy. And you should know what is the teratogenicity caused by methimazole. There are multiple teratogenic adverse effects of methimazole. That includes, if you see the teratogenicity of the skin, that will cause aplasia cutis. Teratogenicity in the gut, there will be choanal atresia, omphalocele. Teratogenicity in the heart, there will be development of ventricular septal defect. Teratogenicity in the head, there will be development of dysmorphic faces. So this is the teratogenicity of the methimazole, right? And yes, why propylthiouracil is replaced with methimazole in second and as well as third trimester? Let me tell you, in second and third trimester, organogenesis is over. And propylthiouracil, it will cause the severe adverse effects compared to that of methimazole. And that is the reason why in the second and third trimester, your propylthiouracil is replaced with the methimazole. So propylthiouracil, it will cause the liver damage. So that is the reason why propylthiouracil is replaced by the methimazole once the organogenesis is over. And yes, which drug is better for the nursing mother? That is another very important question. Let me tell you, it is again methimazole which is considered as the drug of choice even in the nursing mother. Then yes, what are the adverse effects of propylthiouracil and as well as methimazole? Both of these together, it can cause agranulocytosis, right? This is the important adverse effects of both this propylthiouracil and methimazole. Now, what is the permanent therapy for the Graves' disease? See, permanent therapy for the Graves' disease is the radioactive iodine. So, radioactive iodine that we give is, that is iodine 131, right? Very important question. That is iodine 131. Now, this iodine 131 can cause the permanent treatment for the Graves. Now, what are the indications for the use of the radioactive iodine? So, whenever there is a large thyroid gland, you can use this radioactive iodine. Multiple symptoms of thyrotoxicosis are there, we can use this radioactive iodine. High levels of thyroxine is there, is another indication. And high titers of thyroid stimulating immunoglobulin are present. That is also an indication for the usage of the radioactive iodine, that is iodine 131. And what is the precaution while using the antithyroid drugs? See, patients with the Graves already they might be on antithyroid drugs. Then what is the precautions you will advise before starting this iodine 131? See, when you want to start the iodine 131, 2 days before, right, 2 days prior, you need to discontinue the antithyroid drugs. Okay, and why is that? Because the antithyroid drugs, if they are there, they may reduce the cure rate of the radioactive iodine in the hyperthyroid diseases. So that is the reason why 2 days before starting this radioactive iodine, you need to stop the antithyroid drugs. Then What are the adverse effects of the radioactive iodine? Let me tell you, radioactive iodine will cause the destruction of the thyroid gland and the individual will land up in the permanent hypothyroidism. But this will happen like 2 to 3 months post administration of your radioactive iodine. So that is the reason why you need to monitor the thyroid hormone levels after 2 to 3 months, and if there is hypothyroidism you need to start the hormonal replacement therapy. And what is the indication for subtotal thyroidectomy? So subtotal thyroidectomy is indicated in a pregnant female, that is in second trimester, in children, and as well as when the thyroid gland is so large and it is causing the compression symptoms like dysphagia, dyspnea and hoarseness of voice, then you need to do subtotal thyroidectomy. And lastly, yes, this is a very important clinical pearl. So remember the hyperthyroid and physical examination. In Graves' disease, there will be painless and diffuse enlargement of the gland. In subacute thyroiditis, there is painful and diffuse enlargement of the gland. In Plummer's disease, it is painless, right? Painless and nodules are being present. And in factitious hyperthyroidism, there is no thyroid enlargement or thyroid is not being palpated. So please remember, only in case of subacute thyroiditis, you will have a painful thyroid gland. With this, I'll wind up this session on this very important topic of the hyperthyroidism. Thank you very much.